Margaret Eichmann, homemaker. Charles McLean, healthcare and business coach. Charles, there we go, thank you. Susan Parr, Vice President for Academic Affairs, Lewis and Clark College. There you are, thank you, Susan. Janet Powell, Real Estate Industries Group Assistant Vice President, Securities Pacific Bank of Oregon. Welcome to all of you. We hope to see you often. We'd like to thank club members who were responsible for helping these people join us. They are Jean King, Gus Mattisdorf, Bob Shoemaker, Bob Smith, and Bob Will. We appreciate your work on behalf of the club. Several announcements. First of all, on Wednesday, February 27th, we will have an open forum. It's called, Will Your Child Get into College? Barriers to Higher Education. This open forum is sponsored by the Education Standing Committee, and it'll feature a discussion on academic requirements and financial costs involved with admissions to public and private institutions of higher learning in our state. Panel members are Dirk Edwards, CPA with Edwards and Myers, Shirley Clark, Vice Chancellor for Academic Affairs, Oregon State System of Higher Education, Edward Schaefer, Director, Center for Population Research at Portland State University, and Diane Sakamoe, Director of Student Financial Services, Lewis and Clark College. This open forum will be held at U.S. Bancorp Tower, noon to 1:30 p.m., 26th floor, conference rooms B and C. The forum is free and open to the public. 1 week from today, on Friday, March 1, we will have Marin Alsop, music director and conductor of the Eugene Symphony Orchestra. She'll speak about the challenges of being a woman pioneer in a male-dominated field. She's considered one of America's leading young conductors and is a two-time recipient of the Leonard Bernstein Conducting Fellowship to the Tanglewood Music Festival. She made history this past May when she became the first woman to conduct the Boston's Pop Orchestra in its 107th year history. We will be here at the Portland Hilton. Pathways to Leadership. City Club's leadership training course will be offered again beginning in March. This is the third series of this course, and it's been very popular. Enrollment is limited to 21 people, so if you're interested in the course, please get a brochure. I think there's some on your tables, and there's some at the main table as you came in. Sign up early. This course is based on Stephen Covey's 7 Habits of Highly Effective People. The course is taught by trainer Linda Langley, who heads her own management training and consultant firm. If you want some more details, please feel free to call our Executive Director, Nancy Hedin, at the City Club office. We also want to remind our radio audience that we would welcome you as a guest at a City Club luncheon. You do need to make a reservation, so please call the City Club office by Wednesday at 5 p.m. and talk to Jenny. She can sign you up. For City Club members, we want to remind you that you too need reservations. We do have a few extra tickets sometimes, but we can't make promises. So make your reservations by Thursday at 2 on the City Club reservation line. Today, our board host is Lloyd Anderson, member of the Board of Governors. He will have the privilege of asking the first question. The second question today will be asked by Human Services Standing Committee member Teresa Julness. She will ask her question from the floor. After those questions are asked, City Club members are encouraged to ask questions from the floor. That's one of the privileges of membership. Please remember that these are questions, not statements. And one to a customer, please. Now for today's program. Back in 1987, Senator John Kitzhaber and the legislature proposed we expand the number of women eligible for prenatal care under Medicaid by reducing coverage for other expensive medical procedures, such as transplants. The Oregon plan was immediately in the news, and rationing of health care was debated far and wide. Medical ethicist John Golinsky spoke before the club and worked with a state committee to set up and develop eligibility criteria for transplants should private funds become available. Then the State Health Services Commission came into being. Within the last week, this group announced their rankings of medical treatment to help the state systematically allocate medical resources to the low-income folks of our state. Is this good public policy, or is it tough medicine for the poor? Our speakers will present their views. State Senator Robert Shoemaker will speak in support. He's a native Portlander, graduate of Harvard Law School, and a former City Club president. In his second term representing Senate District 3, he chairs the Health Insurance and Bioethics Committee and is a member of the Judiciary, Labor, Telecommunications, and Consumer Affairs Committee. Tom Higgins will speak in opposition. He is Vice President for Strategic Planning, Public Policy, and Community Relations for Blue Cross and Blue Shield of Maryland. His background includes experiences such as being the co-founder and editor of Health Week, a business newspaper for the health industry, service as Deputy Secretary to the Cabinet and former Associate Commissioner to the Social Security Administration, 3 terms as a state legislator, and Director of the Department of Human Services for our own Multnomah County. He too was active in City Club, serving on several committees and the Board of Governors. Senator Shoemaker will speak with us first, and then Mr. Higgins. Please join me in welcoming both of our guests.
Thank you, Mary, and greetings. It really is a pleasure to be here. The club has been very close to my heart for probably 30 years. And I'm not as active today as I was a few years ago, but that is no diminishment of my regard for the club, and I plan to be active again in the future. Mary did a very nice job of introducing the issue, which was dramatized in 1987 with the Kobe Howard case. What I'd like to do is fill in between then and where we are today and where I believe we are headed. First, some statistics, if you can bear with me, to describe the problem. Oregon is not unique. We are in the same situation as every other state in the union. Unlike the others, I think we are doing something about it that has some prospect of really addressing the problem. About 450,000 Oregonians, which is 18% of the state's population, do not have health insurance or other access to health care. 44% of those people are unemployed, 15% of them work part-time, 41% of them work full-time. While 190,000 poor Oregonians are receiving Medicaid, which is the federal state program to provide health care to the poor, funded 2/3 by the feds and 1/3 by us, approximately, there are about 120,000 poor men, women, and children below the federal poverty level who are not covered by Medicaid, and over half of these are women and children. For example of what it takes to be covered by Medicaid, a family of 4 making slightly less than $6,500 a year, that's $541 a month, is too rich for Medicaid. So think about that. So the people who don't have coverage, either because they're not on Medicaid, although unemployed, or employed but their employers, for whatever reason, are not providing health insurance, are really in a bind. As a consequence, they don't seek routine medical care because they cannot afford it. When they absolutely have to have care, they will get it at an emergency room or elsewhere. By that time, of course, whatever was wrong has progressed to the point where it's a lot less likely to respond to care, and of course a lot more expensive to treat. That cost is not charged to the recipient because by definition they can't pay for it, but neither is it absorbed by the hospitals or the doctors, although it is to some degree. It's passed along, and so it appears in the health insurance premiums that you and your employers pay. And that's the phenomenon known as the cost shift. The problem is getting worse and not better. As more and more costs are shifted, insurance becomes more and more expensive. Exclusions from policies are ever increasing. Some employers discontinue because they cannot afford it, and the gap widens. So that's what we're faced with. Now, when you're in that situation, you've got essentially three choices. You can either cut people from the program, and that's what we've done, or you can cut the payments to the providers, and we're doing that too, paying the doctors and the hospitals less than their normal and customary charges, sometimes to the point where it doesn't compensate them for their own expenses, let alone their own time, which then leads to a great disincentive to provide those services. Or you can cut the least effective services. And it's that latter approach that we're taking in this state. How to get there from here is what I'm going to describe in the next few minutes. Essentially, you've got several broad choices. You could have the government do it all, which is what we would call socialized medicine. Or you come up with some combination of the government doing it for the poor and employers, for the most part, doing it for the employed. That's the system that this country has, and that's the system that we're proposing to stay with. To do that, we came up with 3 bills in the last session, in the '89 session, which are now the law of the state. We're now in the process of implementing those. One of those it was numbered Senate Bill 534, and it's to take care of that group of people who are uninsurable because of high-risk conditions, pre-existing conditions such as diabetes, heart conditions, and so forth. In order to get those people out of the insurance pool so that they would be provided care but wouldn't adversely affect premiums, we created a high-risk pool in the '89 session. Not very adequately funded yet, but it is available at a fairly high premium cost to those people with uninsurable conditions. So that takes care of a small block. Senate Bill 27 is the main piece. That's the Medicaid piece. Its elements were these. First of all, emphasize preventive care. Recognize that you do better to keep people well than to only attend to ailments once they have arisen. And so the state, as a matter of policy, has decided that we will emphasize preventive care. Secondly, deliver care to the poor via managed care, prepaid, capitated, managed care, which is an example of that is Kaiser Permanente, the health maintenance organization. There are other examples, but essentially you put the incentive on the provider to deliver no more services than are absolutely necessary, since they're paid in advance per patient, per month, or per year. And then when a patient needs care, there is no further payment. And that has proved to be cost effective. It has its own problems, and that, of course, is quality control. And we will be dealing with those problems as we move more and more into managed care. The third piece of the Senate Bill 27 is the big one, and that's prioritization. And to do that, we established a Health Services Commission in the state of 11 people, 5 of whom are physicians, 6 of whom represent, I think it's a social service worker and a nurse, and then 4 public members. And they were given the task of drawing a list of health services from the most valuable to society to the least valuable to society. And I will return to that at some length in a few minutes, because that is the key piece, and that's the piece that was delivered to us the day before yesterday, and here is a copy of the list. We also need a waiver from Congress in order to do this, because we're breaking all the rules. Medicaid has become encrusted with mandates that every state must follow if it is to be entitled to the federal match, which is 2/3 of the money. Our experiment departs from many of those, so we need Congress's permission to do what we propose to do. Technically, we need permission from the Health Care Financing Administration, but as a practical matter, we need congressional blessing. And we will be going for that in a few months. Assuming we get that, so now we can put the Medicaid piece in place and get it up and running, and we're taking care of everybody, families and children, below the federal poverty level. Let me at this point digress to say the groups that we're not covering, who are also entitled to Medicaid: aged, blind, and disabled. They will continue to receive Medicaid as they are now, at least for the time being. And those in need of mental health services, those also will continue to receive those services as they are now for the time being, although the time is near when mental health services will be delivered via the prioritization process. So when we get Senate Bill 27 in place with our waiver, then Senate Bill 935, which is the private piece, clicks into place. And that really is the bigger of the 2 pieces of legislation, although most of the people out there don't realize this. That bill, now law, turns to all the employers in the state who are not now providing health insurance for their employees and says to them, by 1994, you shall. And the health care that you will provide will be at least as much as we are providing to the public on the Medicaid side. At least as much. You've got to provide at least those basic health services that we have decided to provide on the public side. This then becomes an Oregon health standard that essentially everyone is entitled to. The delivery of those health services to the employed population and their dependents will be paid for primarily by the employers, the split being normally 75% on the employer, 25% on the employee, and a 50-50 split for dependents, with adjustments to that for those who are on the lower rung of the earnings ladder. Employers will be given a tax credit over this past year and the next several years to encourage them to get on board the program. We now have a modest program in place, and tax credits are available for those who get aboard that. That would pick up some of the cost to the employers to allow them to make a transition into carrying the health insurance cost as just a part of their cost of doing business. Also, and a very important piece, is a statewide risk pool that we are establishing that would be available to employees of small employers. Presently, that's defined as anyone with 25 employees or less. We may expand that. We recognize that a small employee group does not provide an adequate pool for insurance. the larger your pool, the more predictable your costs, and thus the more insurable your risk. So we are creating a statewide risk pool that would accommodate all employees of small businesses who wish to be a part of it. And that pool would be funded in part by premiums from employers that would be equivalent, well, would be the premium necessary to provide that insurance, or essentially a tax on those employers who don't sign up voluntarily. The state would then be in the position, probably through the Office of Medical Assistance Programs, to be the payor for the health services to that now large pool of employees. We're contemplating merging that pool with the Medicaid pool and possibly with state employees to create a really large body of people that the state would be the payor for their health services. This, we think, will allow the state to operate very efficiently and cost effectively, and of course will give it a good deal of clout when negotiating with providers. So that's a very important part of all this. So that's the plan. Presently, as I said, the high-risk pool is established. Small employers are being offered a low-cost policy at about $55 a month per employee, and we now have the list. The list has 808 items on it among 17 different categories of treatment. It will now go up to actuaries, which is also part of the plan. Their job is to determine the cost of delivering each service on the list to the Medicaid population to be served. And we're talking cost. It's not a percentage of normal and customary fees. It's what does it cost the provider to deliver the service, including as a component of cost, compensation to the provider. Very complicated process of determining that, but I understand that it is essentially complete. The actuaries will return the list probably in late April with all the costs attached. At that point, the ball is in the legislature's court, and it will be our job to draw the line. We are not entitled to change the order of priority. That was the job of the Health Services Commission. We take the list as it is. All we do is decide how much of that to fund. And that is going to be a very interesting political process, you can be sure. But we are committed to it. We agreed to do this in 1989. It's going to come to us, and we're going to do it. We are probably going to find that the present level of Medicaid funding is not adequate to fund what we would believe to be an adequate level of services. In other words, we're probably going to have to find some more money. And we recognize that that's a challenge that lies ahead. We may be able to deal with that this session. I hope we are. If not, it may have to wait a little while. But we'll know those things better when we get the list back. But believe me, we're not going to fund that list, draw that line, unless we believe we are really providing an adequate level of services to those in need of health care. If we can't do that, we'll wait until we can. But when we can do that, and let's assume that that is during this session, then we'll go back to Washington with our funded list and say, okay guys, this is what we're going to do. Please let us do it. And we expect to have a good deal of support. In this state, supporting what we're doing is large industry, those who are now bearing the cost shift, large and middle-sized industry, labor, hospitals, doctors, and also consumers. Not all consumers, and Some of the consumer groups have a bit of a wait-and-see attitude to see how we really do, how's the list look, where do we fund it, but they are on board so far as the philosophy of the plan is concerned. And I see that Ellen Pinney is here, who represents the Oregon Health Action Campaign, and I believe I'm stating that accurately. She's nodding her head that I am. So that's a description of the plan. I'd like to spend the next few minutes, if I still have a few, talking about the list, because I think that is the critical element of this, and it's the one that is in the news right now and is being debated. The Health Services Commission was organized to do 4 tasks. Community participation, to determine what the public valued the most. She says my time is up. Well, maybe we can get to how we pulled that list together and what went into it during the questions, and I suspect that that will be appropriate because I think Mr. Higgins will probably be speaking to the list. So why don't I defer that until then, and I think I can probably conclude at this point. I would like to say one thing, though, that I think it's important to understand that this is a beginning. This is not the end. We have no illusions that we have designed the perfect vehicle. This is the first time this has been done. As Dr. Paul Kirk said, he is on the Health Services Commission, chairs the Department of OB/GYN at Health Sciences University. This is a first cautious step to start society thinking differently about the collision of our unlimited expectations and our limited resources. We believe the issue is not whether this is the perfect answer. The issue is whether the Oregon plan is a substantial improvement over the status quo. And we believe that it is. Thank you very much. I look forward to your questions.
Thank you, Senator. Mr. Higgins.
Thank you very much, Mary, and thank you, Bob. This is an obvious pleasure for me. Coming back to Portland, to Oregon, is a homecoming in every sense of the word. I have so much affection for the people that I know here, and so much respect for the leadership role that Oregon has played for as long as my memory serves me, at least, not only in this area but in so many areas of public policy, that I'm frankly not surprised to be back here talking about yet another Oregon innovation. Perhaps it would be best if I started by emphasizing some points of agreement between myself and Bob Shoemaker, because our points of agreement are perhaps larger really than our points of disagreement. There's no question but that to continue the process of rationing the way we have done in the past with Medicaid would be unconscionable. And there's no question that to ration health care in our society is not only necessary but desirable. So let me be clear about that. You have to ration health care because there's an almost insatiable demand for it. And you can't continue to ration Medicaid along the lines of eligibility or provider reimbursement, because to continue to do so frankly only perpetuates the worst kind of cost shift and in some ways the most unfair kind of rationing that exists. Nevertheless, I do have some serious reservations that I think are largely shared by a lot of people outside the state of Oregon as well as within the state about the particular approach that's embodied in Senate Bill 27. And I'd like to raise some of those concerns so that you might understand where I'm coming from, but also why I think this particular approach will continue to encounter some serious difficulties in getting approved by the Congress and by the Healthcare Finance Administration. But then, in fairness, I would also like to suggest another approach, which I've had the opportunity to discuss briefly with Senator Shoemaker and with others, which I think, and I stress I think, might be more persuasive to the Congress. First of all, let me raise some of the concerns. The most obvious one, of course, is that we can't really evaluate this approach until we know how much money there's going to be. I mean, as excited as I am to be back here, as mindful as I am about Oregon's pioneering traditions and compassion and the rest, there is a sense that I get when I'm back here that we have concluded that the only way that our citizens can be persuaded to pay the bill for an acceptable, decent level of services is to first see a large number of those services dismantled, and then, having felt a sufficient amount of pain, hope that people will respond accordingly and will be able to see those services restored. I hope that's not the case. And these institutions took many, many years to build. When I come back here and find plans mandated as a result of ballot measure 5 that would involve the closing of health care clinics for the poor and the abandoning of very important services across the spectrum, education, health care, and the like, I feel badly about that. I would hope that before that's done, that really the citizens of the state would respond in a way that makes it clear that they don't want those services to be dismantled. So that on this particular issue, trying to evaluate what the fairness, if you will, of a rationing approach to Medicaid services for what is really the poorest part of our population is almost impossible without knowing how much money there's going to be in the pot, in effect without knowing where the line's going to be drawn. And as a practical matter, it's very, very difficult when you're confronted with 800 plus services to figure out how to draw that line within the available amount of dollars. The second issue, I think, really goes to the heart of the philosophical objections that have been raised to this, and that is that out of necessity, this begins with the Medicaid population. And in fact, it begins with that portion of the Medicaid population, the AFDC population, which is the youngest, the poorest, and in many ways the most vulnerable part of our society. Rationing, by definition, the test of fairness for rationing, it seems to me, is over how broad a population the rationing is going to occur. And given that the state has the financial responsibility not only for Medicaid, but also for its own employees and for other publicly funded recipients, it seems to me that it would be more fair not to begin with the Medicaid population, but, if you will, to move to the point that Senator Shoemaker said they were going to move to, which is to include a much larger pool of publicly funded recipients. I think it's a very, very difficult philosophical issue to get over. If you start with people who are the youngest, if you will, the youngest and the poorest, you're automatically, it seems to me, casting a very, very important obstacle in terms of any fair rationing scheme. The third, and it's a corollary to that point, is that it also perpetuates the cost shift. If I could put my finger on one issue that more than anything else has destroyed or seriously eroded social insurance in the United States over the last 10 or 15 years, it would be the pernicious effects of the cost shift that continues to accelerate as government withdraws from its rightful responsibilities, and the burden of caring for the poor, the hidden cost, so to speak, of providing that uncompensated care continues to be shifted to the private sector. I have a very great concern that no matter where the line is drawn in this benefits package, from a macroeconomic point of view at least, the logic is that the cost associated with not providing necessary medical care will fall upon the private sector and will therefore more dramatically undermine the very fabric of social insurance to begin with. It seems to me that another approach to rationing might be well considered. Going back some 25 or 30 years ago, in various parts of the country, we began to see the existence of what are called small area variation studies. Now that's jargon, but let me explain to you just a little bit about what it meant and what its ultimate significance is from a public policy point of view. Researchers started looking at a number of select procedures. They looked at what the variation in practice styles were for physicians and other specialists within a certain area compared to physicians and specialists in another area doing exactly those same procedures. What they found, and this has been more or less a constant, at least with, say, the top 20 or 30 procedures, what they have consistently found is tremendous variations in the practice styles of those physicians. So that, for example, for a coronary bypass operation, for a laminectomy, for prostatectomy, et cetera, what you find are variations on an order of 6 or 7 or even 800%. That then, in turn, led to a number of studies called medical effectiveness or medical outcomes research. That research looked at the fundamental question as to whether or not there were any important differences in quality, in outcome, depending upon, whether you were at one end of that spectrum of invasive, aggressive treatment or the other end of the spectrum. And again, what the empirical evidence is starting to show, although it's by no means complete, is that at least for, say, the top 20 or so procedures, those which account for over half the inpatient hospital days in the United States, the differences in outcome cannot explain these differences in practice styles. So as a result of that, a number of very compelling reports have been issued in the last 2 or 3 years, last 5 or 6 years really, that suggest that as much as 1/3 of the medical care that's performed in the United States is medically inappropriate in that given situation. Now we're talking about very large numbers, very, very large dollar amounts. And it raises, it seems to me, the core philosophical issue in considering how one goes about rationing health care. If you take the approach of trying to ration health care by, in effect, limiting the benefits that are in the Medicaid program or any program, therefore, you're left oftentimes with the kinds of situations which were most graphically represented by Kobe Howard. In effect, you're left with a 12-year-old boy who was denied a bone marrow transplant for his leukemia, which might very well have been life-saving. No consideration really being given to the age of the person involved, where they are in their lifespan, the rest of that. I mean, no matter how well-intentioned the system, you wind up, it seems to me, with very, very difficult ethical dilemmas like that. If, on the other hand, and moreover, you have to do it on the basis of, as you can see, over 800 different procedures, which lead to an administratively complex system, to say the least. If, on the other hand, your rationing system is predicated on an empirical database that focuses on effectiveness, that in a sense tries to influence the practice styles of your providers so that the excess utilization in our society is reduced and the inappropriate utilization is reduced, then it strikes me that you've got a much happier outcome. You achieve substantial savings to the system, you assure high quality medical care, and you assure care that's delivered in the most appropriate setting at the most appropriate level. We have some great resources available to us because of the interest in the federal government in this. We've established 23 different patient outcome research teams around the United States that are looking at these various procedures. Some are a lot further along than others. Perhaps the best known is the work that's been done on prostate surgery at Dartmouth. But there are others that are fairly far along. It strikes me that if a state commission were to identify on the basis of utilization those procedures, those providers, excuse me, who statistically are the outliers, who are the people whose practice styles are at the high end of the spectrum, so to speak, that it may very well be, and certainly has been the case in other parts of the United States, that they can be influenced to alter their practice style on the basis of this outcomes research. This has been done. I mean, it does work. There is a lot of information that is certainly yet to be collected, but the focus of the rationing effort, not tomorrow perhaps and not next year, but the focus of the rationing effort essentially becomes effectiveness and appropriateness instead of trying to, if you will, draw a line around a circle of benefits, the necessary outcome of which is that the medical care uncompensated below the line, if you will, is then going to be transferred to the private sector. I think it's important to bear in mind where we want to go as a society. And here I must say I speak only for myself, not for Blue Cross and Blue Shield of Maryland or Blue Cross and Blue Shield of Oregon. But we have pioneered systems right here in Portland, beginning with the work that Don Clark did around Project Health, continuing through Health Choice. We've pioneered systems, I think, that show a fair, rational, equitable way to both maintain competition within the healthcare delivery system and to make sure that people get appropriate levels of care. I would suggest that there is no reason why the state can't use its leverage on a statewide level to forge a similar private and public partnership on the statewide level, if you will, a kind of voluntary all-payer system. Bring in the results of outcomes data, influence providers accordingly, maintain a high quality of health care, and assure far greater equity across all classes of people. The shining ideal that Oregon always represented, and still represents, it seems to me, is an approach to basic services like health care that isn't divided out along the lines of class or welfare. And I would hope that that will continue to be a guiding principle in the way in which you approach this issue. Thank you very much.
Thank you, Tom. The privilege of the first question goes to Lloyd Anderson, and Lloyd would like to ask the question from his seat. Lloyd?
I'll ask Bob, but perhaps Tom would want to respond to this also, and that is that if you look at the system we have in this country and the cost of the system on a per capita or gross national product basis, the cost is higher than it is in most other industrial countries in the world. And if you look at the statistics on mortality for certain kinds of diseases, it's also higher. Are you trying to patch together a system that is not really working that well, and that the remedy is simply going to prolong something that in fact requires radical change?
We're not trying to patch together a system that's going to cure all the problems. This is a plan to provide access to health care to all people at an affordable cost, which we're getting at through a variety of ways. Managed care is one of them. Probably having the state become a significant payor is another one of those. Also in our hopper this session are bills that will, if they're successful, change some of the way that health insurance is written, moving toward what we call a community rating system, where the state in effect is one large insurance pool, and to discourage or perhaps prohibit insurance companies from ever narrowing the pool of risk that they are willing to undertake for a specific premium. We think we can get at the problem of this country's excessive cost of health care through these means. It could be that we'd have to move to something like the Canadian plan someday if we're not able to do it in a sort of a more traditional American approach.
I think that almost by definition, when we spend 13% of our gross national product or close to it on health care, and other nations, Canada I think is about 9%, Great Britain about 6%, and yet we leave 33 or 34 million people uninsured or without access to health care, that it takes a more radical solution than we've been able to come up. The difficulty is, of course, that health care really is a national problem, and it was pretty fashionable over the 1980s to say that issues like this, health care reform, ought to be dealt with by the states. But I think that violates a fundamental principle. You know, we're a national community, and it ought not to be based on an accident of geography, whether you happen to get fair services in Mississippi or Montana or New England. I mean, this requires, it seems to me, desperately, a national solution. The idea that the federal government should only be in the business of providing for the national defense and delivering the mail is crazy, and you can't do it. It's very, very difficult. I mean, I commend Oregon legislators for being willing to at least try, but it's really much more of a national problem, it seems to me, properly, than a state problem.
I could just add a postscript because it's relevant. We recognize that. We think it is a national problem. However, it's one that the nation has not been able to solve, although it's been trying to solve it for perhaps a generation. The states are seen as the laboratories of democracy. It's a way to try new things and learn from that and make little mistakes instead of huge 50-state mistakes. We're asking that we be given a chance to see whether ours is a path that might lead toward a national solution.
The privilege of the second question goes to Teresa Julnes, member of the Human Services Standing Committee. And I will ask you to ask your questions quickly, and let's have rapid-fire answers because we have a long line out there. Teresa.
A detailed question. I'll do it very quickly. Theory is sound, several problems. Senator Kitzhaber has mentioned that we need additional monies in order to support this program many times. Last year, Senator Shoemaker, you stated that one of the beauties of this program is that we have increased access with no additional monies going into this program. And today you stated that we may not put additional monies into this program. Using your numbers, we have 190,000 currently eligible with 120,000 coming into it, increased reimbursement. It's obvious we need more money. Given the political environment, what taxes do you see possible in this state?
We haven't decided upon a specific tax that we would seek to supplement what we can expect from the general fund, and we really don't want to do that until we know how much we need. We won't know that until we get the list back from the actuaries and can see how much of it we can fund with the resources that we can expect to obtain from general fund.
Well, John mentioned yesterday some new specific taxes have to be created. Is there one that you think?
No, not that I'd be willing to discuss at this point.
Next question, please.
Don Sterling, a member. Bob, I wonder if you'd respond to Mr. Higgins' suggestion that a better way to go is to test outcomes and try to force the cost of medical care down.
Okay, I don't disagree with Tom, and outcomes research was a very important part of the compilation of this list. That is one of the most important parts of it. The Commission adopted the quality of well-being measure that was developed by a doctor at the University of California, San Diego, named Robert Kaplan. It's called the QWB scale, and this played an important role in developing the list. Outcomes research is in its infancy in this country. We are perhaps helping to move it along through this process, and we would expect it to be accelerated now that we're underway on this, and that it will influence changes in the list as time goes on. And there will be changes. The Health Services Commission is a permanent commission. It is mandated to revise the list every other year. And outcomes research will be very much a part of that. So I don't disagree with that at all. But I don't think we ought to wait and not do anything until we've got all the questions of outcomes research resolved and then rest solely on that. I think that would be folly.
Yeah, I think that would be folly too. However, there are things that I think would be perhaps more productive that could be started on now. The problem with trying to mix the concept of medical effectiveness, let's call it that. Outcomes research sounds silly. Let's call it medical effectiveness or appropriate care or whatever. Trying to mix that approach with the idea of a list it's apples and oranges. The fact of the matter is that by definition, again, virtually everything on that list, or certainly the 20 big procedures, if you will, are appropriate for some people some of the time and not appropriate for other people other times. So it's not just a question of saying, we'll pay for this one and not for that one. It doesn't work that way. Some people need coronary bypass surgery, but not all people who get coronary bypass surgery need it. Some people need prostatectomies, but not all people who get them need it. And it seems to me that there is a structural flaw in approaching rationing by trying to make a list and drawing a line. Maybe the easiest way to think of it is to think of the most common way of rationing. When we think of rationing, since time out of mind, we think of triage, battlefield conditions. You go onto a battlefield and you decide who you're going to try to save and who you've decided has gone too far or can't benefit from at least what you've got to offer at that point in time. It is an existential decision, and a fair approach to rationing has to be an existential decision.
Next
I'd only
question.
comment that the list does accommodate that.
Next question, please.
Larky Dneff, City Club member. I heard Senator Shoemaker just answer part of my question, which is that the list will be reviewed every other year. I want to direct a question to him then, and to Mr. Higgins too, please. Do you think that that's frequent enough? And I use the example, let's say that this list is approved and you get the congressional waiver.
Mm-hmm.
But let's go back 30 years. Cancer would probably fall treating cancer would probably fall somewhere towards the bottom of the list. But now, because we've treated those people who were once hopeless cases, we can now cure almost 50% of all cancers. What if, in between the review for this year, they come up with a list cure for AIDS? I mean, would people have to wait another year until it's reviewed? In other words, the mechanisms for updating the list.
This first year, we are going to review it annually. So we'll have 2 reviews in the next 2 years. But I think the reason it's biennial is that our legislature is biennial and we appropriate biennially. There is access to the emergency board, and if something like that were to occur, like a miracle cure for AIDS, the Health Services Commission could recommend that to the emergency board, and there could be additional funding.
Poppy Warren, City Club member. Mr. Shoemaker, Bob, I think you know I direct a federal demonstration project in Portland, the Good Samaritan, on Alzheimer's disease and related dementias. One of the project's goals is to come up with a national public policy to deal with long-term health and social care. My question, as our population ages and chronic illness climbs exponentially, how does Senate Bill 27, or does Senate Bill 27, deal with the non-acute categories, i.e. the chronic categories like Alzheimer's disease and other dementias that do not have immediate outcomes?
I'm not sure I can answer that completely, Poppy. One important answer is that the Medicare is available for people over 65, and most of the Alzheimer's problems are visited on that group. Also, the care of the aged, blind, and disabled is not attended to in the list. Mental health disorders, which some of what you mentioned are those, are to be included in the list, and in fact the list does include mental health disorders. There was a mental health subcommittee which prioritized mental health services. Those are integrated in the list. They will not be funded, however, nor costed at this point. We will return to that and meld them in perhaps this session. Does that answer your question?
Mostly. I just want to add that Medicare does not adequately deal with long-term care at this point.
Yeah.
It does under the demonstrations, perhaps, and I have a great concern in this area.
Long-term care is in the category of age, blind, and disabled care, is provided via Medicaid, and we recognize that a serious problem that we must turn to.
Great, thank you.
Just a caution on the administration of this that I haven't had a chance to think through. Obviously, this just came out yesterday, and when DRGs came around for Medicare, a giant industry got formed. You know, it was like a full DRGs, I'm sorry,
New
called
York waived them.
diagnostic related groups, and they're a price-setting mechanism for Medicare. A huge industry got formed. It's like a full employment act for lawyers and accountants and consultants and so forth to basically try and help providers figure it out. And you can either put a pejorative connotation on that or a helpful connotation. But the fact of the matter is, this is very complicated. And for any practitioner in a real world setting, you know, who's already not terribly incentivized to take Medicaid recipients because the compensation's so terrible, to try and work with this administratively will not be easy.
Next question, please.
Vivian Solomon, City Club member. This is for Mr. Higgins. I heard you describe a difference of several 100% in the practices used by varying physicians. My question to you is, what involvement have you solicited or obtained from healthcare providers or associations such as the AMA in streamlining treatment practices to those which you deem economic and effective?
Well, actually, we're getting a great deal of cooperation, and I think that's an important point to bear in mind. There are a lot of people who think that physicians are going to be resistant or are resistant to changing their practice styles. Big concern, particularly after the earlier studies that were done 25 and 30 years ago. But in fact, without exception, each one of the subspecialty groups, when introduced to the evidence behind those studies, have in fact made important changes in their practice styles. And listen, it goes beyond physicians. I mean, there's a study that came out just about 2 months ago that just compared hospital utilization rates between New Haven and Boston. You know, both major medical centers of excellence. Huge difference. I mean, on an order of like 40%. The truth of the matter is that if you can get people's attentions who are healthcare professionals, if they feel like you aren't using a club, but instead are using good evidence. I'm really quite optimistic about that.
Thank you. Next.
Rusty Goldie, member. In view of the complexity and the expense entailed in these great administrative problems of these systems, wouldn't it make sense for us to expend and work toward getting a national health insurance program that treats everybody like the Canadian system?
Well, as Bob has already observed, you know, you've got, and I'm sympathetic to the point. I mean, the point's well taken. I mean, Oregon probably can't and shouldn't wait for the federal government to come around and do a more sensible approach to health policy. One thing, at the risk of appearing to be just a little too parochial, I'd like to point out, though, that you have a model in Portland that was pioneered by Project Health, that Health Choice has used for other audiences, that vastly simplifies the administration and the marketing of healthcare plans to targeted populations. It maintains the virtues, if you will, of competition between those plans, but eliminates a tremendous amount of the obvious cost associated with duplication in marketing efforts, and results in consumers who make informed choices. I mean, there's a great model here to be built on that I think Oregon will move to in a private-public partnership. There's no reason why the state shouldn't aggregate its purchasing power, as Bob suggested, and then go to the largest employers in the state and say, you know, let's get in this together, and then put together, if you will, fashion a marketplace that is competitive, that has multiple payers, but that eliminates an awful lot of the obvious administrative waste.
And that's exactly what we're moving to do, and we hope that we will succeed and we can demonstrate that the Oregon plan is actually superior to the Canadian plan. The Canadian plan isn't perfect. That's the second most expensive health care in the world. And it is plagued by very long waits for some treatments, decisions regarding who must wait made at the ministerial level rather than at the public level, and a second tier of health care which is actually provided in the United States. If you start digging into the Canadian plan, it is a good plan. It works very well in Canada, but it is not a perfect plan.
I'm sorry, we're out of time. We must adjourn. Let's thank these gentlemen for this wonderful presentation. We could hear again tomorrow. We are adjourned.
It's so hard to